Welcome everyone to today's webinar. I'm Morgan Hafner with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Sue Champion has more than 30 years of clinical experience in the perioperative setting. Her experience as a clinical leader includes management and administrative roles in surgical services and central sterile at acute care facilities. In her clinical management roles, she was responsible for department planning, organizational effectiveness, and staff development. She was accountable for driving results that included fiscal and quality improvement activities, ORIT system building and optimization, supply flow efficiencies, and cost savings and inventory reduction. She also had fiscal and quality responsibilities for the sterile processing department in her facilities. Sue joined Cardinal Health Resource Products and Services in 2001 and is now a senior manager for the clinical marketing department. In this role, she has consulted on national and international accounts for clinical processes and practices, preference card management, supply chain, inventory and equipment/instrument management. She holds a master's degree in business administration with a concentration in corporate finance and a bachelor's of science degree in nursing. She is a member of the Association of Perioperative Registered Nurses and maintains her certified nurse in the operating room certification. Sue is also a member of Sigma Theta Tau, a National Nursing Honor Society. Sue, I'll now turn the floor over to you.
Thank you, Morgan. Welcome, everyone, and thanks for joining. As Morgan said, my name is Sue Champion, and I am a registered nurse and senior manager at PreSource Products and Services with Cardinal Health. In the next few minutes, we're going to discuss how your surgery center can cut waste and costs today by optimizing your custom procedure trays. You would likely agree that doing both has never been more important as you continue to maintain patient throughput and quality of care. After this presentation, you should be better prepared to discuss how to cut waste and cost in custom procedure trays. You should be able to describe how product standardization is a key to optimizing custom procedure trays. You will be able to review how supply data drives better decisions around reducing costs and improving efficiencies. You will be able to outline a primary pitfall of optimization as well as a major myth. And you'll be able to review how to gain clinical support for optimizing your custom procedure trays. Now let's get started by sharing why Cardinal Health is uniquely qualified to help your ASC improve processes, support patient safety initiatives, and streamline inventory management. With more than 40 years of experience, Cardinal Health is a recognized leader with a top ranking for transforming the healthcare supply chain to meet new challenges around costs, revenues, and outcomes. In particular, Cardinal Health is the leading medical surgical distributor for the ASC market, and each of the perioperative nurses working for Cardinal Health on our clinical team average 20 years of OR and supply chain management experience. Now let me tell you a bit about how my division of Cardinal Health, PreSource Products and Services, supports surgery centers just like yours. PreSource was an original developer of custom procedure trays for surgery centers. You may remember us as Allegiance or Custom Sterile. And throughout all of the changes that we have experienced in the healthcare industry, PreSource has been there learning and growing right along with you. As procedures began migrating to the ambulatory surgery space, PreSource has been there supporting your changing needs. Our clinicians bring their own experiences and combine it with the knowledge they gain from working with our varied customers to ensure that we are staying on top of changing trends and medical advancements. Each year, we produce nearly 59 million procedure kits for ASCs and other sites of care, and we are involved in 50% of all surgeries performed in the United States. Every day, we're tailoring trays to the unique challenges of surgery centers. Now let's take a look at a few of these challenges. For starters, surgery centers have less space for inventory. And I can see you all shaking your heads on that one. And so that means that you have to be more efficient with ordering and storing products. Then there's the challenge of turnover time, which is absolutely critical to the financial health of the surgical space. It's really important anywhere within an operating room, but for surgery centers, it's even more imperative. As a result, clinicians can't afford to be needlessly distracted by materials management issues. And yet, you're often responsible for that inventory management. Think about how many hats that you wear in your role as an ambulatory surgery clinician. It's the clinical, but also the inventory many times. Now, this becomes an especially tough challenge when too many supplies are pulled for a procedure, then they have to be restocked. Surgery centers, for the most part, are a daylight operation, meaning the doors typically close around 5 p.m. Now, after a full day in the operating room, who has time to do that restocking of all the products that were pulled but not used? And just as importantly, what surgery center would want to pay nurses overtime to restock them? In the ambulatory space, many times you do not have the luxury of having ancillary staff to help with those duties. It does fall back on the clinicians, which is why it is so imperative to get your arms around that. And then that brings us to the issue of waste in the operating room. As I just mentioned, products are often pulled for a procedure that are opened but unused. So then they have to be thrown away. There's not much you can do with them except maybe put them in your mission bin. That's not only the high cost of discarding these opened items, but also the labor cost of restocking the ones that you didn't open and didn't use. If they're restocked after hours, there's the higher cost of paying overtime as well in many instances. Now think about this. How pervasive is this problem? In my own experience, as many as 20 to 50% of products that are pulled go unused. That is a staggering number, and the costs really add up quickly. For an average surgery center performing 5,000 procedures a year, just $50 of waste per case can equal $250,000 annually. Think about that. Imagine what you could do with $250,000 if it were available to you to improve patient care. Together, we face the challenge of how to support quality outcomes while reducing waste, controlling costs, and improving workflow. One impactful way we can do that is to optimize custom procedure trays. To do so, we can focus on creating a template of components that include the approved items covered by a GPO contract or that are on your particular formulary, and also looking at clinically and economically justifiable preference items. But how do you get there as you're looking to optimize your procedure trays? What can you do to get the optimization process started at your own surgery center? An important key to tray optimization is product standardization. It's critical to reducing costs and improving efficiencies at the same time. And it is a proven strategy. In fact, 30% of surgery centers already do it, and the other 66% are striving every day to get there. Why is that? The simple answer is that standardization benefits everyone. For the supply chain professionals, there are fewer SKUs to manage, so staff members can work more efficiently when they are doing the stocking, the inventory, and the rotation of that inventory. And for the clinicians, even more importantly, it means less clinical and supply variation, which can improve OR efficiency. So the physicians can maybe perform more procedures in less time and do it efficiently to meet all of the guidelines that you have. On the other hand, you can look at it, a lack of standardization leads to the clinical and supply chain variation that increases both product and labor costs. Not only is standardization critical, it has never been more essential. The need for standardization is more urgent than ever. I don't have to tell you that. You feel it every day when you walk in those doors. Costs have continued to rise over the past 15 years, while the reimbursement discount to hospital outpatient payments has increased in recent years. The chart that you're seeing really says it all. In 2008, the discount was 35%. In 2017, it's projected to be 46.1%. In other words, the ASC discount has risen by nearly 1/3 since 2008. But what does this mean for you and your facility? When the lines on the graph move in opposite directions, you are tasked more and more to work harder, faster, and smarter to overcome the deficit. You are asked to be more inventive around cost savings and cost-cutting opportunities. At times, that demand seems almost impossible. But there are things that you can do, and standardization is one of them. In the past, attempts to standardize custom procedure trays were commonly unsuccessful for several reasons. Number one, and probably the most prevalent, there's little or no time to dedicate to the process. You may have had difficulty getting the right people together to discuss and agree on a standardization strategy. And that's even more difficult now if you're working within an IDN or a group of facilities and looking to standardize. Relying on anecdotal versus hard data evidence. The fact is that physicians and staff need hard data evidence to be convinced that tray optimization is essential. And the final reason is that large data sets are difficult to grasp. For example, a single pack can contain from 30 to 60 products for each procedure tray. And how many procedure trays are you looking at? Maybe you have 15 to 20 in an ambulatory surgery space. If you look at the number of individual components and all of the packs that you're dealing with, it is almost impossible to get your arms around where do you need to focus. Without advanced data analytics, it's an overwhelming challenge to identify opportunities to standardize. However, when you do use data analytics and visualization, the variation in custom procedure trays can be identified almost immediately. In my own experience, stronger visualization is essential to quickly identifying standardization opportunities, so the surgery center can take quick action and make better decisions to cut the waste and save money without affecting your quality of care. Think about those spreadsheets where you have all of your bills of material for your packs. Sometimes they can go on, and they can be columns long and columns wide and rows long. And how do you look at it and ever determine what you need to do and where to start? If you look at this screen, though, on the right-hand side, you see what I call the Skittles chart. This is from an advanced analytic program that shows you your variation immediately based on color coding. Call it Skittles because to me those different colors look like Skittles. You can call it whatever you want. It's actually a bubble chart. But it points it out right away rather than looking at all of those letters and numbers that are jumbled on an Excel spreadsheet. Data analytics can also help ensure that your PAC program is aligned with your surgery center's volume and the case mix. When it is, your surgery center can improve both efficiency and your bottom line. So how can you get started with your own data analytic efforts? Major data initiatives can include setting inventory levels based on utilization history. This is not a new concept, but it really is very difficult to do at times. Our practices and our habits are hard to break, and in the past, setting inventory levels based on utilization rather than practice of filling the space was not even thought of. When you saw a space and you're refilling it with the supplies, you want to make sure that you had the supplies that you needed for your surgeries and when you were pulling cases, so you filled the space. Did we ever think about looking at our utilization so that we had just the right amount to cover your variations and to cover your peaks and your valleys, but to make sure you had the right amount of product? Another way to use data initiatives is by lowering costs by standardizing products across your PAC program. Ensure that you are using the same component from the same manufacturer in all of your PACs. Think about suction tubing. You have different diameters and lengths of suction tubing. Sometimes it's warranted based on the procedure that the PAC is supporting, but many times you have that variation when it's not necessary. You can also look at lowering costs by being open to accepting clinically equivalent products that are lower in cost, and after you've already come to conclusion that you can maybe work with it, work with the physicians and the other staff and getting them to support the initiative also. You can conduct a side-by-side PAC comparison to identify potential cost saving and standardization opportunities. You can replace the PAC components with lower cost, clinically equivalent products. And here's one that's really important. You can add off-the-shelf items to your PACs to increase efficiency and lower cost. Really look at your procedure and what you're using, what you're pulling all the time, and what you're having to open. Anything that is used all the time makes better sense to be in that PAC. Makes it much easier to handle your inventory and your practice if you do that. During some standardization projects, optimizing a custom procedure tray can result in getting to the lowest common denominator of products inside the kit. That may sound like a good idea, but what that actually does is have the kit result in a skinny custom procedure tray, one that is the lowest common denominator, so it doesn't take into account the variation of the components. Maybe the same components, but they're from different manufacturers, and rather than getting to the root of what you really need, you just decide to not have it in the kit. However, this approach simply transfers the variation from the custom procedure tray to the items pulled off the shelf. The variation is still there. It is just less obvious, and it makes it more difficult to manage. And the results can be higher acquisition costs as well as increased labor when you are picking your cases. So after all of this talk, you're probably thinking, what's the solution? To truly save money, the surgery center must analyze the cost of supplies used not only in the procedure packs, but also the items that are pulled from the shelf and added to the case cart. This is your true procedural cost. By analyzing the combined costs of both, you can have an accurate baseline of overall supply spend by procedure. Then you can make more informed decisions about how to reduce the overall variation and the costs. A wise person once told me that you can't manage something if you can't measure it. So knowing and understanding your procedural baseline is the first step in managing your supply spend to meet your financial goals. Now let's talk about one of the major myths associated with tray optimization. The myth out there is that all procedure tray variation is due to clinical preference. Are you all kind of smirking at that? Clinical preference. It doesn't always happen that way, and it's not always the fault of the clinicians. It's true that some supply variation is the result of physician preference, such as choosing either a push button or a rocker switch on the cautery pencil. Patient-specific items are also a source of variation, but that variation is always going to remain because patients do not come in one size fits all. But there are other root causes as well. Let's take a look at a few of them. As staff members come and go, variation is naturally introduced, such as having a different needle counter for every pack. We call this historical variation. It just happens over time. Sometimes the product ends up on the shelf because of a back order or the surgeon preference. Back order is over. Maybe the surgeon has gone, but that item is still on your shelf. And unless you are really paying attention to that, what happens? You continually replenish that stock. You fill the space, or even you look at it by usage, but you are constantly reordering that supply. And because it's on the shelf, it continues to get used and pulled at time, maybe because the preference cards haven't been updated. But there really is a comparable product with higher usage sitting right next to it. This is historical variation. Then there's contractual variation, which is driven by GPO volume discounts and rebates. For example, changes to a health system GPO contract can impact the ASCs within the system. So you change over, but maybe you had some of the old product on your shelf from the old GPO contract. Well, after it sits there for a while, but nobody really makes a conscious effort to do anything about it, it actually becomes part of the historical variation. Some variation is caused by medical devices that are designed to work only with specific equipment. A perfect example I always think of is insufflation tubing. I know when we started our first surgery center, we got equipment that was being used within the main operating room because all of a sudden we were told that we had an ambulatory space. Well, you get the older equipment and all of a sudden you have 3 or 4 different types of the same equipment, and each piece of equipment mandates that you have a different disposable tubing to go with it. So that's where that variation comes from. If you're a newer surgery center, you may be fortunate that you purchased all of your equipment at the same time, so it's all the same. But I probably feel a lot of head shaking that, yes, I have varied equipment within my space. Here are a couple of additional examples. You've likely seen variation caused by differences in clinical practice. The simple fact is that different physicians can prefer different practices. And in this one, it's not just the physicians. It may be the clinical staff. It could be your scrub tech or the RN scrubbing for the procedure that likes to use something because they like it, or this is what they trained on. The other thing that really causes variation is the differences in draping practices. Think about it for a shoulder arthroscopy. It can be done in either a lateral or a beach chair position. Both of them are legitimate, but they may require different draping practices. And maybe that draping practice for that position and that physician, all of a sudden the physician's not there, but you still maintain the drape on the shelf. That's what causes your variation. And finally, there can be variation within health systems because different facilities prefer different practices. A lack of system-wide standardization can lead to system-wide waste and inefficiency. In today's world, where everybody's partnering, people are merging, surgery centers and acute care facilities are being bought and being merged into a larger organization, there's natural differences that you have to work on. And that doesn't happen overnight. It takes time, but it should always be a thought that remains in the forefront for everybody. Now let's turn to a challenge that I would imagine many of you are thinking about right now. How in the world do you gain clinical support for tray optimization? If the surgery center has a culture in which physicians and staff are regularly involved with managing overall business results, then they are far more likely to embrace the optimization process. That makes sense. If you people are involved, then they're more likely to understand where you're going and why. Now, the good news is that nearly 40% of physicians report being already engaged with supply cost management. Advanced data analytics can help physicians and staff to be involved more easily. Remember, physicians require hard data evidence to standardize, so use this tool to gain stronger buy-in from them. Show them the facts, not the anecdotal stories that you come at them with. But keep in mind that optimization does not require physicians to invest a lot of time in the transition. You can use the data analytics to make judgments and come up with resolutions and solutions before you present to your surgeons. And that way, you are helping to maintain the surgeon's time while at the same time driving that data analytic behavior. For example, most standardization activities can be delegated to the surgical techs familiar with the surgeon's techniques and the clinical staff that support the supply chain processes in your facility. In addition to making advanced data analytics available, be sure to engage with physicians and staff and make them part of the optimization process from day one. You can do this with one-to-one discussions, communicating with the staff members who know them well and their needs well. You can do it with bulletin boards, monthly meetings, whatever your process is right now for communication and how you share information with anything else. Use that also to help support and drive your standardization opportunity. But while you're doing this, make sure that you make data analytics a cornerstone for your discussion. Data can make a powerful case to gain clinical support, and I know this from firsthand experience. About 10 years ago, as I was working with Cardinal, I was asked to go to an IDN to help them standardize their packs. Before that was really the thing to do. But they knew within this facility, within this group of hospitals, that they needed to standardize to start gaining efficiencies and cost savings. At that time, we worked with the Excel spreadsheets, we had pack samples, we had some observation information, and then we had the anecdotal knowledge of the clinical staff to help us make those decisions. And at that time, it was very difficult to obtain utilization information for the cost impact that the changes we were proposing would really make. When we presented our recommendations to the surgeons, many of the recommendations were rejected because we weren't able to convince the surgeons to change based on the anecdotal stories and what we thought was a good idea. It's kind of funny, but about a year ago, I went back to that same IDN for another standardization project. And some of the same surgeons were still there and remembered me. I'm not sure if that was a good thing or a bad thing, but I had to go with it. But this time, using data analytics, I was able to support our proposals and to show the surgeons the hard facts. And this was a vast improvement over the last time. When the surgeons were able to see the metrics, the conversation moved from anecdotal statements to discussions around the financial implications to change. Now, there were still some rejections. It wasn't all rosy, but the overall outcome was much more positive and had a much higher financial impact. One of those surgeons that said he remembered me came up to me after our last meeting and said, you know, if you had done it this way the last time, we would have been more open to the changes and we would have been enjoying some of the cost-saving benefits for quite a while instead of just getting to them right now. So if you look at it, here's a case study summary. The challenge for the IDN that we were working with, this was an IDN with 10 facilities, and we were looking to standardize 3 kits, their total knee, their total hip, and their lap gallbladder. The challenge was, where do we start? What was the most impactful or benefit to the facilities? And why did they come to Cardinal? We've had a long-standing partnership with them, and we've always brought innovation and solid, actionable resolutions to the challenges. And the implementation details, we were able to come up with a process that identified the focus that we should be looking at. We created a timeline for the meetings and the decision making, and we were the go-to person and looked on the follow-through on the to-dos to ensure that the timelines were met. And we used the existing process then to work on other standardization opportunities within the IDN. But what did that case study show? Here are some of the results, and I'm talking about the total knee as I talk about these results. There were 10 total knee packs across 10 facilities. We were able to standardize them to 1 kit. Their overall supply spend for total knees was at $1.1 million before standardization. We were able to lower that to $940,000. Keep in mind that is just for 1 pack. Here's one that I really want you to pay attention to. The pack spend went from $662,000 to $906,000, while their single sterile spend went from $346,000 to $35,000. Those two spends, when we talked before about your true procedural cost, if you focus just on the cost of the pack, and you would see that it had gone from $662,000 to $906,000, you would have raised your hand and said, whoa, stop, we're not going there, it costs too much. But if you looked at the single sterile spend and that we were able to drive what made sense into those kits, single sterile spend went down dramatically from $346,000 to $35,000. So that shows the dollar impact. But what about the labor impact? On that last line, if you see the single sterile pick went from 44,000 to 16,000 items picked annually across 10 facilities. Think about the labor savings in the case pick and also in the setup time when you have reduced your single sterile items that you have to open by that much. Now, within the same IDN, when we did the lap choles, we realized that not only will you get down to just 1 kit is not always the way to go. For them, for the lap choles, we ended up creating 2 laparoscopic cholecystectomy kits. One facility always, 100% of the time, did cholangiograms, so that it made sense to have a kit with the supplies for the cholangiogram included in it. And then we created a kit without the cholangiogram supplies for the other facilities that did not do it routinely. But still, we were able to look at this, and we got them, and there were more facilities involved in this one. There were 13. We were able to reduce them from 13 kits to 2. Dramatic when you're talking about managing that supply inventory. So let's wrap up by recapping the value of optimizing your custom procedure trays today. It will reduce the variation that causes waste and inefficiency. It will improve clinician workflow and patient throughput. It's a way to help you control your costs more effectively. And it will support your patient care and quality outcome strategy. And most importantly, it does improve your bottom line. But outside of that, even more important than that bottom line, I believe, is that it makes you better prepared to meet future challenges. You think we've been challenged in the past, and we've seen changes come and come and come at us, but I believe that we're going to see even more in the next 18 to 24 months. You have to be ready to meet those challenges, and it is essential in this time of growing complexity and uncertainty in the healthcare world. Thank you all again for your time and attention, and I'll be happy to answer any questions. So take it away, Morgan.
Thank you, Sue, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. And it looks like we have several questions coming in from the audience. So our first question for you, Sue, is I hear you talk about the importance of standardization, but what should come first? Standardization of components or standardization of packs?
That's a really good question. You know, in the perfect world, I would always say the standardization of components would come first. Much of the time, variation in componentry is the result of individual preference or historical reasons. Gaining the consensus for the standardization of components is very time-consuming, and trying to standardize packs while component variation exists often leads to distorted procedural baselining and a longer project timeline. Without that component standardization, packs are reduced to the lowest common denominator, which I talked about in the presentation, and that hinders efficiency and cost effectiveness. However, you can do component and pack standardization at the same time if the committee overseeing the project remains focused and centered on the ultimate goal, always bearing in mind that communication, discussion, and compromise are needed to gain consensus on the component choices.
Thank you for clarifying that, Sue. And our next question from the audience is, customization is really important to our facility, so if we standardize our packs, does it take away from our ability to customize?
Oh, absolutely not. It actually does the opposite, and it drives the customization that you need. Because the goals for any standardization project should be to create a program that meets the needs of the end users, supports the procedural demand, and contributes to the financial health of the facility. When a standardization project is approached with these goals in mind, customization becomes the linchpin that promotes the process and drives success.
Great, thank you so much for pointing that out. We have an audience member who would like to know more about, in their ASC, they're finding that the physicians are making arrangements with vendors without consulting them or material managers about bringing in new products. And so how should this audience member address this challenge?
That is a common problem that many ASCs deal with. And my recommendation is to explore incorporating these following steps. Work with the administrator and leadership of your center to establish a new product committee that requires all products to be presented to the committee before approving. Explore implementing a vendor credentialing program to control vendor access. Review your policies and procedures to see what policies may already exist for the new product entry, but maybe are not being reinforced. And if you don't have a policy for vendor access or unauthorized product entry, then write one. Then discuss with the physicians and the vendors. Recommend a policy that non-pre-approved product will not be paid for, and discuss this with vendors and physicians. With a written policy in place and a product review committee, you can take that control back and manage the products coming in and out of your center.
Thank you, Sue. That was really helpful for understanding. And we have another audience member asking, my ACA is half physician-owned, and we struggle with standardization because physicians want what they like and or normally use. Any tips on how we can get them to see the cost savings in certain supplies?
Another common problem that many physician-owned ASCs deal with. I hear you. We find that physicians respond best to data and numbers, and I can't stress that enough. When you identify those items for which you have found a clinically equivalent substitute, present the two products to the surgeon with the annual cost and the annual cost savings of switching to an alternative. If the center is half owned by physicians, it's their money that will be impacted by this shift. By showing them the products side by side and the cost side by side, many times they may get on board. Another consideration is to clarify if complaints are coming from the physician or from the staff. Many times it's staff preference rather than physician preference, because most commodity products used in the OR are not physician sensitive. You could also enlist the help of other physicians at your facility to overcome the resistance to change by those who use the product out of habit. Getting a champion is always the way to work at it to help drive that change.
Great. Thanks for that great question and an informative response. It looks like we have time for one more question, and an audience member is wondering, what is your recommendation on what to use, what is your recommendation on when to use customer packs? Should we have custom packs for each specific specialty?
You know, a pack solution should always be developed based on your procedure mix, your procedure volume, and the commonly used items for those procedures. Items in custom packs should be used 90 to 95% of the time or not included, because then that leads to waste. Packs can be created based on specialty, but analyzing common draping practices is the best place to start. You may have multiple packs that are used in the same specialty. Orthopedics may have an arthroscopy pack, an extremity pack, a hand pack, a total joint pack. On the other hand, you can also have the same pack cross different specialty areas. For an example, an extremity pack may be used for both hands and podiatry procedures. But it really depends on your mix and the supplies that you use. We suggest that you look at least a usage of 10 per month before you create a custom pack. If it's a lower volume procedure that you're doing, then look for the standard packs to see how they best support what you're doing. If you are part of an IDN now, it really does make sense to look across all of your different facilities to see if they have a pack that meets the needs that you have and that would work well, rather than creating something new or going out to a standard kit that may not quite meet the need that you have. But always look at it from the standpoint of what's your volume and what is your procedure mix. By using those commonly used products in the packs, it will help to reduce your touch points, which then impacts your inventory management, and that creates many more efficiencies within your supply chain.
Thanks for breaking that down, Sue. And that is all the time that we have for today. I want to thank Sue for her excellent presentation and to our audience for participating today. Enjoy the rest of your day, and we really look forward to having you join us for future webinars.